Hello. Today I'll be talking about why do we need OCT. These are my financial disclosures, none relevant to this talk. So whenever we talk about glaucoma, we talk about two things. We talk about structure and function. And structure in general refers to the optic disc, specifically the neuroretinal rim and the retinal nerve fiber layer. And the one device that we have today which can measure all of these is the OCT. Function refers to white-on-white perimetry, and that is typically a visual field analyzer. So whenever we look at structure and function, there's a curvilinear relationship between the two. The number of ganglion cells are lost at a faster rate than the visual field changes. And if you look at this graph here, what you will see is that for this much of a drop in the ganglion cells, you see hardly any change in thresholds. And in fact, what happens is this is a typical curvilinear pattern that you see when the ganglion cells are dying, but the change starts becoming apparent once a lot of ganglion cells have actually died. And the little picture here shows you what happens over the entire range. So what this means is in this part of the disease, functional change, there is visual field change, is not as effective as structural change in detecting change of damage. And we had evidence for this from the ocular hypertension treatment study, which was a multicentric randomized controlled trial, which looked at what happened to patients with ocular hypertension who were treated to either observation or followed up. And they assessed optic discs with stereo photographs taken annually and assessed by experts, and visual fields were done using a Humphrey visual field done every 6 months. And interestingly, what they found was that 36 of 817 patients in the medication group and 89 of 819 patients in the observation group developed POAG. And when you look at the end point, that is, how did they detect disease change, you found that it was the optic disc only in the vast majority of patients. More than 50% of patients, it was the optic disc change which was detected earlier than a visual field change. More disc changes occurred, and this sort of fits into what we discussed earlier, that in early disease, significant structural changes occur before visual field changes are measurable. And this is partly because threshold determination on visual field testing is highly variable. So why don't we use the optic disc more commonly to assess progression? And there is a reason for that. And that is because when you looked at these 88 ophthalmologists who looked at serial optic disc photographs of 54 eyes with varying degrees of severity, and they decided to classify them as stable or progressed based on what they found. The agreement between different ophthalmologists to decide whether an optic disc was stable or progressing was actually not very good. And this is a challenge that comes when we use something like the optic disc assessment, and we look at a clinician's interpretation of progression. So at the minimum, we require disc photos to see what is changing. But if we have something which is more objective, like the OCT, that makes even more sense. And we had similar information from our own study where we looked at longitudinal analysis of the optic nerve and changes in patients with primary glaucoma. So when we are using structural damage, we again found that it is better to use objective measures rather than subjective measures like optic disc assessment to detect change. And the best objective measure we have today is the OCT, because the OCT gives you disc findings, it gives you RMFL findings, it gives you macular RMFL change. And these are all three important parameters when it comes to looking at glaucoma. I'm going to share with you a few cases. This was a young glaucoma suspect with a family history of POAG, whom we have been following up for a fairly long time. And you can see that except for a few pressures in the early 20s, most of his pressures are in the normal range. So we had serial disc photographs on him. This is the right eye, taken some years apart. And when you look at the right eye fundus photograph, you can actually appreciate a small nerve fiber layer defect there. This is his visual fields done over an almost 8 to 10 year period, and that was rock solid, not showing any change. When you look at his OCT, it looks fairly stable here, but you can see that the inferior RMFL has started to show some change on the trend analysis. And in fact, even when you look at the actual values in the inferior quadrant, they start showing consistent change. And when you look at the macula, you start seeing consistent change happening, and you see the temporal raphe sign over here that's going on. So this is somebody with early glaucoma who you're seeing the first change on the OCT. This is the other eye of this patient, and you can see this eye has established neurofibrillary effects superior and inferiorly. And this person had a visual field effect in that eye, and also had corresponding OCT changes in the fellow eye. So this is somebody who we would have elected to watch if we did not see these OCT changes, and we likely prevented him from developing further damage in this eye. So in early disease, OCT helps detect damage because, as we spoke earlier, in early disease, retinal ganglion cell change occurs before perimetric change. Now, this is somebody who we followed for about 18 years, and this is a graph of his intraocular pressures, and you can see how they fluctuated over time. And he has been in the 25-26 range over time. And this is his combined report, and what you're seeing over here are the visual fields. And this is the RNFL thickness. These are his baseline visual fields. This is the current visual field. This is baseline OCT measurements, and this is the current OCT measurement. And when you look at his current OCT measurement compared with the baseline, you can see distinct change on the macula. And both the retinal fiber layer thickness and the GCL IPL both show changes. His visual fields are consistently normal. And this is his other eye. So when you're assessing structural disease, it is easier to detect change in early disease with the OCT. So this is an ocular hypertensive over 18 years, fairly stable. We had to start him on medication halfway through. But even on this patient, who we think is stable, we are actually detecting change earlier on the OCT than the visual field. Now, this is a third gentleman who you can see over here as look at his visual fields. His visual fields, he does it not very reliably. There's a lot of fluctuation in the fields over time. And then we decided that we'll get his OCTs done, and that's what his OCTs look like. So he obviously had a lot of damage to start with itself. But his visual fields over time really don't show very much of change. But his RNFL map shows changes. And for this, you need to look at his baseline thickness values. His baseline thickness values are in this range, 56, 54. And when you look at it over here, you're definitely seeing a change as compared to the baseline. So this is somebody who does visual fields unreliably. This is the other eye. Other eye also, you can see a fair amount of fluctuation in this visual field, and you can see what happens to this field over here, which he does so poorly, but when you repeat it, he does it better. And this is what happens to his OCT. So his visual fields at baseline are looking much worse than at follow-up because there's a significant learning curve there. But the OCT shows you distinct change over time in the GCL IPL progression. So this is a patient who, if you're going to rely on visual fields alone, is going to be difficult to get the adequate information about his disease progression. So structural tests are useful when patients are unable to do visual fields well, because they give you another way of assessing what's going on. This third gentleman, you can see, shows change on the visual field. And this is the other eye. And here also you're seeing change on the visual field. You're seeing change which is adjacent to fixation. But you don't have too many visual fields on this patient as compared to what you would like. So what you have over here is when you started doing the OCTs also, even with just 3 OCTs, the OCTs are suggestive of worsening disease. So here, what it is, the way we are using OCT is to provide us supplementary information as to what is happening in terms of damage. So when you assess structural damage, when you see both structural and functional progression in a high-risk eye, this reduces your threshold for additional medication or early surgery. You don't necessarily have to, you see change on only the visual field. We have been taught that you need to see confirmation of change on the visual field before you do something. But if you see somebody who's showing a consistent decrease in both the visual field and the OCT, you can maybe decide to hike up medication or consider surgery with that one change alone. I will last share with you the relative odds of progressing by structural and functional tests in glaucoma. So this is a paper which looked at about 462 eyes with glaucoma and 69 normal eyes. And they looked at, they did the study based on trend analysis. They generated slopes of the trend analysis for glaucomatous eyes. And what they found that the eyes which had less severe disease at baseline, you were more likely to detect progression by the STOCT than by standard automated perimetry. This is what we expected. And as the mean deviation got worse, you are more likely to detect progression with the automated perimetry versus STOCT. And this is an example of a patient with very early disease, and you can see that you're starting to see OCT changes over time. And the OCT rate of slope was minus 2.28 microns per year. That was statistically significant, while on the visual field, the slope was very minimal and was not statistically significant. So early in disease, you saw that the OCT was helping you detect change, which is what I showed you with a few clinical examples too. This is somebody with much more advanced disease, and you can see that the visual fields look like they are getting worse even when you just look at them. The OCT overall looks fairly stable. And this is what was seen on the OCT2 because you're seeing hardly any slope over time, while with the visual fields, you're seeing a very significant slope, which is statistically significant. And the reason you do not see that much of change on the OCT over time is because a fair amount of ganglion cell loss has to have occurred before this much of damage has occurred. So the amount of change that occurs after this is relatively less. So in advanced disease, functional tests do a little better. But this is not 100% rule. In fact, in this paper, what they found was that when your mean deviation was about -1 decibels, the STOCT was much more likely to detect progression than the visual field. When your mean deviation was around -10 decibels, both were equally good or equally bad at detecting progression. When your mean deviation dropped to -20 decibels, most of the time the visual field was better at detecting progression than the OCT, but the OCT still detected progression a little earlier in a subset of patients. So basically, this tells you that there is a role for the OCT even in patients with moderate disease. And this is somebody who we have been following up over time. And what you're seeing over here is basically a whole bunch of visual fields which are getting marginally worse, and an OCT which is looking fairly normal. So this is somebody who's had a LASIK, and obviously pretty difficult for us to figure out what's going on with him in terms of the pressure. So his visual fields go up and down a little bit because he doesn't do them that well, but his OCT is looking relatively stable, so we're happy to watch him. So why do we need an OCT? We need an OCT because it's an objective measure of damage. It helps us to detect change early in early disease. And it's also very helpful when visual fields are difficult or a patient is finding it difficult to do visual fields or they're very unreliable. And as supportive information in patients with established defects, then we need to decide whether to treat earlier or otherwise. So it's important to use both structure and function in assessing our patients. And when we're using structure, it's best that we use an objective measure of structure rather than something like a disc photo, which is useful as a long-term document, but it's a little difficult to assess progression on. Thank you.